Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalata from Roots Community Health, reporting for the week of July 7th, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. After a status update on respiratory illnesses and measles, I will talk about the recent CDC Advisory Committee meeting, some of the new estimates released regarding COVID and long COVID, as well as some of the recent record highs that we are seeing not only in measles, but also with flu. First, taking a look at respiratory viruses, and this is showing us each week the percentage that each of these different viruses make up of those tests being done in a clinical setting. And still, by far, rhinovirus, enterovirus, kind of a regular cold virus, is represented in the gray there, is making up the largest share of those specimens, followed by parainfluenza, which is in the yellow. We can see now that human metapneumovirus, which is in the black, has kind of been declining in terms of its share, while SARS-CoV-2 in the red is increasing a bit. So SARS-CoV-2 is now the third most likely to be picked up in those settings for respiratory viruses. And taking a look at the wastewater, we can see that it's still considered very low nationwide, and each of the regions is coming in either as very low or low. And only the South, which is in the purple, looks to be heading up, so something to keep an eye on. And taking a look at COVID epidemic trends, this one looks a little different than the last time we looked at this. So this is letting us know about emergency department visits for COVID, and it does appear that we have either likely growing, which is in the lighter purple, or growing, which is in the darker purple, in many states, especially across the South and in the West. And we are seeing what appears to be growing trends of COVID in Alaska, Texas, Oklahoma, and Mississippi. So this is definitely something that we'll continue to watch, and this is not unexpected, as we know that we do typically have increases in cases over the summer. So this is kind of what we're keeping an eye on. In addition to taking a look at hospitalizations, which we can see looks still pretty nice and flat. So this is pretty reassuring. We're looking up through June 28, 2025 so far, even though COVID hospitalizations are quite a bit more than flu and RSV at this point, since those are mostly behind us for the season. But the COVID line in orange is still looking pretty steady and flat, which is a good thing. But since we see that emergency department visits are starting to head up, like we saw on the prior map, what we're now going to want to look at is if and when hospitalizations also tick up, which we usually expect to see shortly after emergency department visits. But each year, each surge has been something a little different. So this is something we're definitely going to be watching closely. And we know that if and when those hospitalizations increase, that we can expect deaths will also follow behind that. But so far, taking a look at COVID deaths, we're still in a relatively good place compared to really the entire rest of the pandemic. We are at all-time lows in terms of deaths due to COVID for this entire pandemic. So that is very good news. We had a slight increase last week over the week before that, or excuse me, the May 31st ticked up slightly at 199 deaths, and then back down again for the week ending June 7th. So these are the last full weeks that have been reported. So 178 deaths the week ending June 7th. It's about a month ago. But again, because the emergency department visits are just barely starting to tick up, hospitalizations have not begun increasing, then we're hoping for a little bit longer of these death numbers to continue to come down before they might go back up for the summer. So overall, in a decent place here. Of course, this is still a lot of people dying every single week, every single month, all year round. So even though it is an all-time low, we do have to look at the overall big picture, which I'll be able to touch on in just a few moments. But right now, I think it's okay to feel like we're doing much better right now in terms of at least deaths than we have been this entire pandemic. So that is something to be glad about. And taking a look at variants, this is really just to kind of remind us that things continue to evolve as it relates to SARS-CoV-2. But so far, we haven't seen any indication that these changes are causing any increased severity. We've definitely heard some anecdotes about the symptoms being different. And it's true that symptoms have kind of changed over time. Remember, early on when people were losing their smell and taste quite a bit, we're seeing less of that. Right now, we're hearing a lot more about sore throats. This is all more or less anecdotal, and again, not surprising as we see a gamut of symptoms as it relates to SARS-CoV-2, and each variant may show up a little bit differently, but no increase in severity, no increase in the ability to get around prior immunity, either from illness or from vaccination. So that is all positive, but yet things are still evolving. We're still seeing different variants taking over, but so far these are all still related and still related to the formulation that is in our vaccine. So again, no change for the vaccine has been recommended this year. We think that the formulation that is out will suffice even as these variants continue to evolve. And now a brief update on measles. So we can see that we are now at 1,267 total cases of measles. 12% of those, or 155, have been hospitalized, and there have been 3 deaths. So 1,267 confirmed cases as of July 1. So based on how things are going, that number is, first of all, we know continuing to increase. It's likely an undercount in the first place, but even just considering the number of cases that we do know about here at this midpoint of 2025, it's not only about 4.5 times what we've had the entire year last year in 2024 when we had 285 cases, but this actually represents a 33-year high. So as a reminder, the United States declared measles eliminated in 2000 when we were doing quite well with vaccination rates. We had less than 100 cases. Most of those were brought in from other places, and we did not have significant spread locally like what we're seeing now. So if things continue as they are, we will lose that elimination status, meaning that we are going backwards. We're going backwards in terms of our ability to control preventable disease and the spread of preventable disease. And we are increasing the risk for many people, including those who are too young to be fully vaccinated, those who are unable to be vaccinated, as well as some percentage of people who, despite being fully vaccinated, are not fully protected for whatever reason. We know this is a small percent, maybe somewhere around 3%, maybe more. This is all being put to the test now that we are losing our community immunity. So our dipping below the levels of vaccination required for community immunity means that more people are at risk, especially in pockets where vaccination rates are low, but not limited to those areas. Unfortunately, there are outbreaks happening right now in many states across the United States, also in Mexico and Canada. So it does seem like this is something we'll continue to contend with, especially when there is no public health leadership here in the United States, and the appointees that are in charge are actually doing more to exacerbate the situation than improve it. So I have to admit that I, along with probably many of us, have probably taken it for granted that in the past in this country there has been educated and informed public health leadership that could at least be clear when something like the worst measles outbreak in decades occurs, and they would be sure to provide clear directives to the public, clear guidance to the public, to the states, and just to the nation overall about the best course of action, which is obviously in this case to follow the vaccination guidelines that have served us well in the past for measles, instead of political appointees who are casting doubt on all vaccines without any evidence, leaving us with nothing but anti-vaccine rhetoric and innuendo and some blatantly false statements about alternative treatments. So it's sad to say that we lack credible public health leadership at this time. We actually do not have a CDC director. We have not had one since the end of March. They are awaiting confirmation. So instead, we have RFK Jr. in charge of it all, someone known for spreading misinformation about childhood vaccinations, known for touting alternative treatments from which he profits, alternative treatments that do not actually exist or have any evidence behind them. So sadly, there's really no reason for optimism about the direction of this measles outbreak or really the direction of public health in this country overall. So on that note, I thought I would talk a little bit about the ACIP meeting, which happened on June 25th and 26th. I endured much of the meeting, not all of it yet, because it is honestly rather excruciating to watch. So just a reminder that the recently fired 17-member committee was comprised of really some of the world's leading experts that we got to listen to and learn from, and sometimes, yes, disagree with as well. But at least we were operating from the same general set of facts and knowledge. And if you're looking at evidence and knowledge and facts and you're agreeing that you're looking at the same set of facts, then of course, still, there can still be differences in opinion, and there often are and were differences of opinion in terms of policy approaches, how much you want to weigh individual versus public health, and other factors around equity and access, things that reasonable people can feel differently about or can disagree on. And we're accustomed to that. But the current situation is that we went from a committee of leading experts to the newly seated ACIP, which is simply not equipped. And I'm sad to say at this point does not appear to add any value. So I'm not here to make judgments on the individuals on the committee, but I will just say that the committee as it is configured now lacks the expertise to be seen as any kind of source, certainly any definitive source of guidance or recommendations. That doesn't mean they'll get everything wrong. It doesn't mean that they might not get some things right, but they simply just don't have the experience or the expertise, which was made clear by the discussions in the meeting. And so at this point, I would say that their deliberations really did not have value. Maybe it would be entertaining if it wasn't so absolutely serious. Or it may have value just in terms of if you're trying to really quantify and assess what we are up against. It's at least kind of a peek into the lack of any sort of rigor or even competence remaining on the committee. And again, without getting into the lack of communications of individuals on the committee, I think what was really demonstrated in the meeting was a farce in terms of the discussion, in terms of the questions that they asked, and what that really says about the overall grasp of the content that was being reviewed. Also, I will add that there was a fair amount of grandstanding, some complaining about from some of the committee members, how some of them feel like they've been mischaracterized in the press, and they put forward opinions about policies, about things that were not set by the ACIP at all, things that aren't even in the purview of the ACIP. So it basically just sounded like some folks took the opportunity to make it a gripe session. None of them admitted to having any conflicts of interest, although there are many that are known. They only refer to ways in which they don't take money for vaccinations, although one did admit to having healthcare stocks, but still said they were allowed to participate. None admitted to earning revenue for their anti-vaccine stances or for promoting so-called alternatives or profiting off of misinformation and disinformation. So that's obviously a glaring issue. So all of this contributes to my conclusion that the committee in its current form is a lost cause. Now, having said that, I want to make very clear that the caliber of the CDC staff presentations was excellent as usual. And this is really important and should give us at least some reassurance, because that means that serious people, serious entities that are going to be making decisions can at least be operating from the evidence and the analyses that are coming from the CDC staff, which we know the CDC did experience reductions in force. And we know that we lost a number of very talented people, but there are still very capable people there. And the presentations were consistent with what we have come to expect. So today I'm just going to share a couple of highlights regarding the COVID portion of the meeting. But I did include a link in the post to all of the slide presentations from the 2-day meeting in case you want to check that out. So starting off, we do have some preliminary 24-25 US COVID-19 burden estimates. It's been a while since they put this out. The first time that they put it out like this was looking at October through December. So now we have October through June. So they've kind of added to it. And we can see that the burden from COVID-19 is tremendous. We have somewhere between 10.1 to 16.4 million COVID illnesses, 2.5 to 3.9 million COVID-19 outpatient visits, hospitalizations between 280,000 and 450,000. Remember, this is an 8-month period. This isn't even an entire year. And COVID deaths in that 8-month period, somewhere between 33,000 and 52,000. So an enormous burden from COVID, still an enormous burden of COVID hospitalization and COVID death, as well as just the burden of illness. It will be helpful when they update this with the flu and RSV estimates for the season, something side by side. I hope that they will do, but we know that the counts are not complete for flu season. So we'll be looking out for that when they publish these burden estimates before they had it side by side with COVID and flu and RSV. And that was very useful to be able to see that, because we have really a year-long burden of COVID, that everything else is not as stark. But we like to see those apples to apples comparisons. So we'll be waiting for that. But in the meantime, I did want to share a little bit about what we do know about this past flu season, because it is significant. This past flu season, 24-25, is classified as a high severity season overall, as well as in every single age group that we look at. So for children, it was high severity. For adults, it was high severity. And for older adults, it was high severity. And this is the first high severity flu season we've had since the 17-18 flu season. We had the highest cumulative hospitalization rate observed since 2010-11. And sadly, we had 216 pediatric deaths that have been counted thus far. And this is the most we've seen since the 2009-10 flu season, which is a pandemic season. So that was when we had a novel flu strain, H1N1 swine flu, and there was 288 pediatric deaths. So if we look at all the years since we've been recording flu deaths, this is actually the most we've had, if you don't count the pandemic flu year. And so this is very significant. We lost too many children. The majority of them did not have any underlying conditions. They did not get vaccinated. And so this should be truly a no-brainer around the argument for flu vaccine. Universally, it's recommended for everyone 6 months and up. So when the next flu season comes around and we have the new formulation based on the anticipated strains, so sometime in the fall, we really should be making an effort to do better, because it really is unacceptable to have this many preventable deaths of our children. And even with that being a severe flu season, even with that, we still see that we had more infants and older adults hospitalized with COVID than with flu. So this is taking a look at each of the age groups, and this is looking at July through April. So it really is kind of capturing the entire flu season. And we see that on the two ends of this chart, so to the far left, we have the under 1-year-olds, and to the far right, we have the over 75-year-olds, and we see the COVID hospitalizations in red exceed the influenza hospitalizations, which are in blue. So this is important to note that even in a high severity flu season, the burden of hospitalization for our extremes of age is still higher with COVID than it is with flu. Now, I was pleased to see that the committee shared some important information about long COVID, and basically saying right off the top, long COVID is a significant public health threat, and the numbers are truly staggering. So it is estimated that 9.2 million adults and a third of a million, so a few 100,000 children in the United States had long COVID, and those were the 2023 estimates. These estimates are difficult to do. There are some pretty robust surveying methodologies that they use in conjunction with the census. I've gone over them a little bit here before. We're going to need better ways to quantify this, but for right now, we can say that among adults age 18 and up, 3.6% reported long COVID symptoms at that point in time, and 8.4% reported ever having long COVID. So you can see that this all really adds up, and though we are seeing some people improving and getting better over time, this is a huge burden of people already. We're only, still not very far in with this novel virus. So we're on our 6th year, but you've already got getting close to 10% of the population ever having had long COVID. So this means months of time where they had symptoms. And as we can see there in the blue box, over 3 out of 5 adults with long COVID have activity limitations. So this is going to have impacts on family caregiving, on work, on school, and all of the things that we hope that folks are able to do unimpeded. But we see that instead we have this huge burden of long COVID and really no end in sight, because we're not doing all the things that we need to be doing to stop the spread. And so we're still contending with COVID and its impacts all year round. When it comes to children 0 to 17 years old, this is really concerning when we think about the fact that they are young, and there's no limit, unfortunately, on the number of times it seems that you can get COVID. So we know that each COVID infection is a new opportunity, not only for a bad outcome, but also for post-COVID impacts, including long COVID. So to start with this cumulative impact at a young age is very concerning. And so we see that 1.4 have reported ever having long COVID. And this is, of course, the children who can articulate what's going on, or parents who put it together and recognize that this is happening, because we don't necessarily always know exactly, especially with children who may be too young to kind of explain the timeline and things of that nature. But almost 4 in 5 children, so even more than the adults with long COVID, reported activity limitations. So this is really devastating to think about the impacts of this on our population. So glad to see this reviewed by the CDC staff in the ACIP meeting. Now, normally after presenting data like this, so we talked about the burden, we talked about hospitalization, we talked about long COVID. There's a number of other things that get presented, but I just want to make a note here about the usual way things go in the ACIP meetings is that normally you get the presentations on the evidence, on the interventions, and weighing those things out. And then that gets followed by a description of how we go from the evidence to the recommendations. So the framework that's used by the committee and the various working groups that meet and deliberate, and then usually come up with maybe a set of choices, for example, around some of the decisions that the committee might need to make. And then we get to hear the committee's deliberation. We usually get to hear great questions being asked. And even if we might differ sometimes with how some of the committee members vote or what the committee ultimately decides, at least it's clear for the public how we got from the evidence to the recommendations. So unfortunately, in this meeting, This did not happen as it relates to COVID. So some of the working groups never met. And so really the entire section on evidence to recommendations framework was incomplete. So it was really kind of a sad and short presentation. So essentially they were able to go over the public health problem of COVID and the intervention of the vaccine, the benefits and harms of that. But the entire sections where they go over values and acceptability and feasibility of the intervention and use of resources and equity, the entire discussion that we really rely on the ACIP to have and then come up with guidance from there, none of that happened. So part of it seems to be because the plan working group calls did not occur. So even though the evidence seems quite clear, we never got to a recommendation. So to kind of summarize, we acknowledge and showed the data that there is still substantial burden, sickness, hospitalization, and death from COVID. We know that the highest rates of COVID hospitalization and deaths are occurring in extremes of age. And so over 65 as well as under 6 months of age. The best protection for children under 6 months of age is maternal vaccination. That is clear. Deaths can occur at any age, but children under 2 have the highest morbidity and mortality of all the pediatric age groups. So our children under 2, again, those little ones are vulnerable. Also, pregnant women are in a category that is at increased risk of severe disease and negative pregnancy outcomes from COVID, which can be prevented by vaccination. COVID vaccination is effective in preventing hospitalization and other critical outcomes. The vaccine has been monitored rigorously. We probably have more data on these vaccines than any other vaccines by far, and it continues to be monitored rigorously. We have robust safety monitoring, surveillance, and the benefits far outweigh the risk by any measure, by every measure. Yet we had no vote, despite the fact that we are likely heading into another summer of COVID, because we know that we tend to get our peaks in summer and winter. Now, I just want to mention something that they did vote on, which is something that I talked about in the last briefing a couple of weeks ago, if you're interested in checking that out, because I discussed it in a little bit more detail when I talked about their planned agenda, which was the removal of the preservative thimerosal from the last barely any straggling places that it exists, just in the multi-dose flu vials. So, and only for adults. So they voted to do that. They voted to remove the thimerosal from wherever it may still be, very scarce. So it wasn't a surprise. It was very performative. No positive impact is expected. To their credit, one of the committee members voted against this and had significant concerns about how this may impact access, acknowledged that no study has ever indicated any harm from the preservative, and really drove home the point that this is actually a non-issue. So here you have the committee wasting the valuable time of a lot of people discussing a non-issue that, if it has any effect at all, will have a negative effect in terms of reducing access. And meanwhile, they're literally presiding over the worst measles outbreak in decades and heading into a time where we should be making decisions regarding COVID, because we anticipate a summer surge like every other year. So again, underscoring my concerns about the lack of seriousness of this committee overall. So again, despite a lot of clarity in the data and the evidence, there was no vote. So for now, I think we can proceed with the idea that the recommendations are not changed, we hope, because remember, as I reported here previously, RFK Jr. and the FDA have each made unilateral decisions about vaccine guidelines, even though this is not typically considered within their purview. So it all seems very concerning and a little shaky and a little unclear what's really going to happen next. So a couple of points I'll briefly make on this. One is that insurance companies must follow what the ACIP and CDC recommend. So they cannot not cover things that are recommended. Having said that, there's no rule or law says that they can't go above and beyond what the ACIP recommends. And since insurance companies know very well that the vaccinations reduce expensive hospital stays and illnesses and post-viral chronic conditions, it will be in their best interest to continue to cover vaccines irrespective of the guidelines. Will they do that? Will they not? This is something that we will be paying close attention to. So it is worth saying that the American Academy of Pediatrics actually boycotted this ACIP meeting in protest and has affirmed that they will continue to publish their own vaccine recommendations, something that they've done for their entire history, which is almost a century long now. In addition, the University of Minnesota has spearheaded something called the Vaccine Integrity Project. I put a link to their information in the post in case you're interested. There are some very reputable folks on that steering committee. They are focused on safeguarding vaccine access in the United States, and they are supported through grant funding at this time. There are other entities that I'm sure will play an important role, like IDSA, the Infectious Disease Society of America, maybe some other academic institutions, other associations. But this is obviously a very challenging situation. So first off, these groups cannot set official federal immunization policy that dictates insurance coverage or the Vaccine for Children program. So this is the biggest concern, really. Now, again, insurance companies could elect to follow guidance that goes above and beyond ACIP, but none of these other entities can require it. So this creates a significant gap for implementation and for access. Secondly, we're already obviously having issues of disparate messaging, so recommendations across multiple independent groups is a challenge. So perhaps they will consider coordinating with one another at least, so at least there'll be some unification happening somewhere. And then, as I alluded to previously, there are issues of funding and sustainability and also capacity. So the ACIP, the type of review process they undertake is so comprehensive, and it requires a substantial dedication of resources, at least historically it has. So still a lot of questions, but I would say we have a strong scientific community. There are dedicated health and public health professionals across the United States who are actively working to ensure that evidence-based vaccine information and guidance remain accessible and trusted, especially as our federal structures face all of this uncertainty. So, as always, we will continue to bring credible information to you here on the People's Health Briefing and continue to encourage all of us to do what we can to keep ourselves, our loved ones, and our community as safe as possible. Let's remember those best practices to prevent the spread of contagious illness. And in particular, now in the summer, where we know that traveling has been a major driver of the spread of SARS-CoV-2, and we're now also seeing travel-associated measles, which I also reported on a couple weeks ago. So if you're not masking anywhere else, at least consider wearing a high-quality filtration mask, specifically a well-fitted N95, to provide excellent protection from SARS-CoV-2 as well as measles, especially on public transportation and airports, on airplanes. We know that these are high-risk locations with a lot of mixing and new chains of transmission that could be spread all over the country and the world. So at least let's do our part to break those chains of transmission, or at least not be part of the chain. Test if you don't feel well. Make sure you know how to access timely antiviral treatment to reduce your chances of a severe outcome from COVID. And remember, if you don't have a primary care provider, please get one. Know how to reach them before you need them. And remember to eat a balanced diet, stay well hydrated, quit smoking, limit your alcohol intake, reduce those simple sugars and processed foods and artificial ingredients. If you're sick, please rest and recover. We know that pushing yourself and trying to go back out to full steam can actually impair your recovery and may be even associated with post-viral conditions. Otherwise, get some regular physical activity and some fresh air. Manage those stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. We'll see you next Tuesday at 10 a.m.